those of you, is this the first time for anyone here? Okay. So it's a pleasure for me to participate in this session because you haven't probably experienced yet really how lucky we are to be working with Colorado Access as a great RCCO. TRIO is presenting the best data we've ever had in this state on Medicaid recipients, so we're really fortunate, and I feel fortunate to participate in a session like this tonight. I'm a general pediatrician. I provide primary care for primarily kids on Medicaid. I've been doing that my whole career. That's what I did all day today. That's why I was late. In recent years, I've been working with others here in the room to try to develop programs to help medical homes take care of kids on Medicaid. And I'm going to be sharing information about kids on Medicaid. How many in the room are actually involved in primary care for children on Medicaid? Okay, so you know all this stuff. There are others in the room who didn't raise their hand for whom this may be new information, but for those of you who know all this stuff, when you look at it in the aggregate, it really can help us decide what kind of data we need to ask TRIO for, and what we should be thinking about in future agendas for best practices. What's really going to help kids on Medicaid? And so I'm going to go through this really briefly. I promise to take only 10 minutes or so, maybe a little bit longer. So the first page lists 31 health disparities that children on Medicaid experience. So poor health outcomes compared to children on commercial insurance. I've got the sources of the data listed here. They have nearly twice as many hospitalizations, nearly twice as many ER visits, higher rates of diseases that could be prevented by vaccines, unfortunately higher death rates. They get cavities twice as often. They're more likely to be obese. Colorado has sort of as a state, we have more difficulty with teen depression, teen suicide than the vast majority of other states, and the most vulnerable are teens on Medicaid. They have lower immunization rates. Asthmatics, they have twice the rates of hospitalization, emergency department visits. And interestingly, I don't have it on here, but if you're a child on Medicaid, you have the same likelihood as any other child of getting appendicitis. But you have twice the likelihood of having complications from your appendicitis. So they do have poor health outcomes. Those are the things we should be focusing on as we go forward over the months and years working with our RCCO. But we have one of the best safety net systems in the country. We've got some of the best federally qualified healthcare centers in the country. We have private practices, both family practices and pediatric practices, stepping up and providing great care. How can this be true? How can we have these kind of health disparities? And for kids, I honestly don't know what the reasons are for the health disparities with adults, but for kids, it's primarily poverty. Poverty is almost the sole driver on this. So we all know about all the socioeconomic or psychosocial economic determinants of their health, the barriers, everything from income to access to healthy foods, housing, transportation, social supports or lack of them. There's a whole list, of things here. And that's the primary driver, is the psychosocioeconomic issues in the family's life. So, when you're taking care of adults, you're taking care of one person. When you're taking care of a child, you're taking care of that whole family. and all of the socioeconomic issues within the whole family. And that's the primary driver. Then there's a growing field of knowledge really documenting that the stress of poverty is toxic to the developing human being. It's toxic to their brain, it's toxic to their immune system, their cardiovascular system, and their health is really affected by the toxicity of poverty. We also know that in addition, families whose kids are on Medicaid tend to have less experience with the healthcare system, less understanding of the healthcare system. They may have language challenges, literacy issues, not just health literacy, but actual literacy issues, and that contributes. And they have a tougher time accessing a medical home. The average child on Medicaid is actually enrolled in Medicaid 8 to 9 months out of the year. They're not enrolled 2, 3, 4 months out of the year. So they spend 20-25% of their time without health coverage, and that really affects their access to health care during that time. And then their environmental exposures also. So, that explains most of these health disparities, and that really is a societal issue. But there are a number of things medical homes can do to try to minimize the impact of all this. As I mentioned, it's the whole family that's the patient. That takes a lot more time and energy and resources for a medical home, as you know, those of you who are medical homes. And the amount of time and attention and cost that it takes to try to address these issues, as a society, we recoup that over the next 50 to 60 years. Now, with adults, you can make changes in their chronic illness this year and have cost savings in the next year or two. With kids, there are a few conditions for which that's true, but for most of them, the savings are way down the line. And that's another difference. So that really kids require investment now, which is why the ACC, Healthcare Policy and Financing, and the RCCOs are focusing on adults now, because you get pretty quick cost savings. With kids, it's really an investment early, and then the cost savings are later. The adults really do have a number of chronic conditions, and part of our role is to try to prevent these kids in low-income families, prevent them from getting those chronic conditions later on in life. We also want to prevent them from getting these 31 health disparities. And so the focus really with kids is on prevention, and that's sort of where I've been heading with just reminding you about what we know about kids on Medicaid. But oftentimes, the prevention they need is really significantly more intense than commercially insured kids. So, and you're going to hear a great example of this tonight. Kids on Medicaid have roughly twice the incidence of dental caries, cavities. They have a much higher incidence of having to go into an operating room to get teeth repaired, caps and crowns put on at $10,000 a pop. They have this higher incidence. I'll let Karen tell you why that is. But part of the reason is they can't really get access to a dentist in many areas, so they can't get the preventive treatments. Plus, they're just at higher risk because of the higher incidence of the bacteria in their mouth that it contributes to the cavities. So they need more intensive prevention. And what you're going to hear about tonight is a program where in the primary care setting, in the medical home, you can actually provide intensive counseling and apply fluoride varnish to the teeth, sealants to the teeth to help protect against getting cavities. This is something that you don't do for commercially insured kids. And so for most of all this preventive care that they need, it really is more intense than it is for commercially insured kids. So developmental delays, they have a higher incidence, they're less likely to get into treatment, they usually get into treatment later. So we have to intensively go out and try to do developmental screening, identify those delays and follow up to make sure. Same thing with the teen depression. They're the teens that are the most vulnerable in our state to depression, so we need to be doing screening for depression. And there are tools to do this, and HCPF pays medical homes to do this. Postpartum depression is more common in mothers of kids with who are on Medicaid, and so postpartum depression screening is really important. And the BHOs are out there trying to train more providers, mental health providers, to be able to take care of postpartum depression. Immunization takes intensive outreach to get families in, and asthma management takes really more time using clinical practice guidelines. And obesity, what's interesting to me is 30 to 40% of kids on Medicaid are obese. 67% of adults on Medicaid are obese and have complications. So our mission is to try to prevent that. And it takes not just identifying obese kids, but intensive preventive counseling around nutrition and fitness all the way along the line. There are tools to do all this, and hopefully as the months go by, we can bring some of the best practices and some of those tools to the group. And the list on page 4 is just sort of a list of those things that we can do to really have an impact on all those health disparities. And so hopefully we can figure out with TRIO how to collect data to identify need and then document progress. And hopefully we can use these sessions to talk about best practices to do that intensive preventive care.